Thanks, Ian. Thanks, guys. That's my disclosure slide. I've developed everything tonight myself. Quite frankly, I don't really think anything I'm going to have to say has anything to do with my disclosures. So you are the experts in older people with diabetes, at least in terms of care home. That said, I still see lots of these folks in my office. So we started out and differentiating between frail and well elderly. I have a few little sort of homemade rules around ages and stuff like that, but that is slightly verboten. So we always talk in my office about balance, and even with the younger people, you know, we talk about, you know, not too many highs, not too many lows, and that's especially appropriate for older people. Individualize and think shorter term, and I'll show you how all of those concepts come into play when we're talking specifically about targets for blood sugar control. This is interesting. I'm also starting to do some work with doctors who look after patients in prisons and Wilkinson Road. Boy, is that an eye-opener. So CDA does have a position statement on institutional care. This isn't a guideline, but you know, the whole idea that everybody, you know, whether you're in jail or whether you're in a nursing home or whatnot, deserves the highest level of quality of care, timely, affordable, ongoing education and treatment services, and all that kind of stuff. And institutional, meaning where the residents require care and services provided by other people. So these position statements are more sort of political things and useful to us on an advocacy front, but they also help us to focus and to remember, again, the individualization. We're now on our third draft for the 2018 guidelines, so I can't show you that stuff. I'll give you a little bit of a preview. These are the 2013s, and I won't belabor them. Other than saying at that point, we said frail elderly should have a glycemic target with an A1C of under 8.5%. And then we gave some preprandial targets and said, you know, there's still a little bit of a slide based on how frail they are. But I'll tell you in a second how we think actually that has been somewhat misinterpreted, and how we're going to try to tighten it up a little bit on the 2018s. And certainly with severe cognitive impairment, prevention of hypoglycemia becomes the most important thing. And I'll talk quickly about how obviously choosing your pharmacology can help you to get around some of that stuff. And those aren't particularly important, other than the bottom one. Whereas I spend most of my life telling people to, you know, eat less and exercise more and lose weight, that is in fact obviously counterproductive when we're talking about a nursing home population. So it's about, you know, maintenance of caloric intake, maintenance of weight and muscle tone. I have one very sweet lady who is in the sort of end stages of Parkinson's. Her son is my patient. He has type 1 diabetes. She's 100 pounds soaking wet, and and takes very small amounts of insulin. And I get these requests around, well, maybe we should stop her insulin, and that would, you know, help her with her weight. And I keep saying, no. Keeping her on insulin is good for her weight and good for her strength. Let's remember, insulin is an anabolic hormone. Right? It's not going to turn these people into Governor Schwarzenegger 30 years ago, but you know, the symptoms of undiagnosed diabetes are of catabolism. So by giving insulin, I think I'm actually helping this lady's quality of life in terms of helping her maintain her weight and maintain her muscle tone. And I don't care how much food and boost and whatnot we have to throw into her, I'll just cover it off with some insulin. Unfortunately, that is still just a grade D consensus recommendation. The Americans publish standards of diabetes care every year because they have 10 times as many people to write guidelines as we do. We can only put one out every 5 years. This is available online. Just to show you sort of the spectrum of things. So The Americans break things down into healthy, complex or intermediate comorbidities, or very complex poor health. And they show, you know, that the healthy elderly, you know, have a longer remaining life expectancy. They give an A1C goal. They give preprandial glucose goals, bedtime, which is always a little bit higher, and they specifically discuss blood pressure and lipids, you know, somewhat consistent, if maybe a bit more aggressive than what Dr. Rauscher just talked to you about. But again, certainly between the healthy elderly, where you're probably going to leave them alone, versus the very complex, where you're probably going to get rid of stuff. And then they have a whole lot of caveats. But when we were looking at things, we thought, well, you know, we're not American, but we are actually international. So this comes from the International Diabetes Federation, and a global guideline. Doesn't that sound cool? That sounds way better than what I do. These guys write a global guideline, which is probably accepted everywhere except maybe the land of Trump. And so they got a little bit more specific. This was published a couple of years ago. So again, the paradigm that we had in Canada last time was sort of category 1, category 2, functionally independent, functionally dependent. They added a category 3, which is end of life, which I think is appropriate. And then they also sort of subcategorize number 2 there in terms of either just frailty or frailty with dementia. And obviously there's often a huge overlap, but they may be a little bit different. And so the internationals treated things a little bit differently. God help me if I'll ever figure out these new units for A1C that seem to be popping up. So again, as somebody becomes less well, the glycemic targets ease off. They do give a lower end, so functionally dependent frail, whereas we had previously said, you know, up to 8.5%. These folks say this as well. Similarly for the demented in the end of life, where there's a focus only on symptom control. Who was it? Inman's not here. Inman sent me one this week. It takes actually 5, if not 10 years for glycemic control to come home to roost in terms of complications. So if you don't think somebody has 5 years in them, you're not preventing chronic complications. You can absolutely prevent acute complications. And similarly, admittedly, a woman with type 1 diabetes sits in my office this week with an A1C of 6% because she's on a pump, she's on a glucose sensor, but she's rocking a GFR of about 20 because she only got religion about a year ago and she's been diabetic for 30 years. So your complications today are actually best predicted by your A1C 5 years ago. And getting religion only when your A1C or your GFR is 20 rather, it's kind of out of the bag at that point. And so in the one Inman tried to send me, the lady may or may not have had some neuropathy. She had an A1C of 6.3 and she was worried about some postprandial sugars of 11 or something like that. It's like, forget it. So this international guideline, quite frankly, is probably going to form the basis of what's coming in 2018. So these were our goals of treatment in 2013, again, where we divided between the well and the frail. Victoria, of course, is, you know, the home of well elderly. But even at that, I mean, even if somebody's living independently at the age of 88, I don't know what the actuaries would say about whether that person has 5 years in them or not, but even people in the community, you might want to take your foot off the pedal a little bit. While the frail aren't going to get the long-term benefit, you know, short-term complications will land them in hospital, both hypo and hyperglycemia. So let's not forget that part of it. And I happen to think, you know, that not being polyuric and not being incontinent is kind of a basic human dignity. So we just, don't want them to be glucose-uric. We don't want them to be dehydrating. But the whole idea that we can just completely forget about blood sugars, even in a frail elderly person, I will dispute. So I just put this up as the future query. So functionally independent, functionally dependent. So this is maybe somebody who's largely being looked after by a spouse, but in their own home. Maybe somebody more in a care home type facility where they're just there because they need their meals provided. Then off to frail and/or dementia and end of life. We quote, there's a frailty scale by Moorhouse that we quote in the Canadian guidelines. I may even have that. So here's the debate, and here was the problem with one of our earlier guidelines, and something I'm struggling with. So we did put a lower end in if the patient is at risk of hypoglycemia. So we were getting reports that these frail, demented people had A1Cs of 6.5%, and it's like, well, hey, it's under 8.5%. I'm doing a great job. But if in fact they are experiencing hypoglycemia, if they're on sulfonylurea or insulin, we would actually like you to take your foot off the pedal, and so we've put in a lower end on those people for the first time. However, if they're not on those sorts of drugs, if they're just on metformin, maybe they're on a DPP-4 inhibitor, if they're not at risk of hypoglycemia, you don't have to feed them chocolate cake to get their A1C up to 8%. So the lower end only applies to those folks at risk of hypoglycemia. So if you've got that elderly person and they're on metformin and a DPP-4 inhibitor and their A1C is 6.5%, that's fine. You don't have to necessarily take them off of medications, certainly not if they're in the first or second or even third category. End of life, fine, you're certainly going to back off. But if they are at risk of hypoglycemia, we have for the first time put a lower end on one of our recommendations. And and so that's where that's going to come from. We've put some sort of suggested targets, and again, just to talk quickly about end of life, which we haven't sort of strictly defined, but we're thinking sort of 3 months, 6 months, maybe a year, symptom control only. Don't worry about their A1C, and just whatever it takes not to have them be glucose-uric. Oh yeah, here's the Moorhouse thing, and that's referenced in the 2013 guidelines, and it'll be there in 2018 as well. So obviously, glycemic targets and blood glucose monitoring go hand in hand. So anybody at risk of hypoglycemia, and this is what I wrote in hospital, the nurse has to be able to check that person if there's any suspicion. They don't need to call me, they don't need to call you. If there's suspicion of hypoglycemia, just empower the nurse to do the blood test for you. If you're starting medication known to cause hyperglycemia, maybe check them for a period of a week. But if they're on orals, their A1C is at target, and they're not on those hypoglycemic drugs, maybe no monitoring, maybe twice a week, right? Because again, you've met your goal. You've met your A1C goal. They're not at risk of hypoglycemia. You're probably not going to see much when you do home blood glucose monitoring. If they're above target, if you're changing therapy, maybe you need to, in the short term, step up. And then one of our rules of thumb when people are on insulin, they need to be checked at least as often as insulin is given. So if they're on once-a-day insulin, they get 1 blood check a day. If they're on 4 shots of insulin, then you're probably stuck with 4 blood tests a day. And any time there's a risk of hypoglycemia. And this, obviously has implications, especially in care homes, for how much work the staff have to do. So we want to try to minimize that as much as possible, but be cognizant of what we're doing there. Just real quickly, this is the ever-growing list of medications for type 2 diabetes. These are the ones that I worry about in the elderly. So I think glyburide has a bit of a unique role within the sulfonylurea class, although all sulfonylureas have risk of low blood sugars. SGLT2 inhibitors, because of the dehydrating effect, we want you to use with care. TZDs, because of their bone issues and their fluid retention issues, those have largely passed. And I don't think there's a big role for the injections for the GLP-1 analogs. So that's just that. You want, obviously, medications with lower side effects, including hypoglycemia. Therefore, maximum tolerated dose of metformin, if not contraindicated. And DPP-4 inhibitors, if we can take the finances and my friends at PharmaCare out of the equation, are probably the preferred second-line agent for elderly patients, because they're about as close to free of side effects as anything that we've had in diabetes land, and they can be dosed down to very low GFRs. Stepped approach to insulin, if you can get by with basal, please. If you need something, BID premix is great in care homes because people get consistent meals. QID only in exceptional cases, but that does include type 1 diabetes, and type 1 diabetics are now living to nursing home age. And we are going to ask that you start to flag your type 1s in hospital. I'll admit to getting a little bit perturbed when people ask me to take a type 1 diabetic whose blood sugars are all over the place because they've been diabetic for 50 years. You cannot simplify people. If their blood sugars are all over the place on QID insulin, they're going to be worse on BID insulin. And because my guy Grimwood, who isn't here, has asked me, though, to say this, never use a standalone sliding scale in a nursing home. Never use a standalone sliding scale in hospital. It requires QID blood testing, and it's a bad thing. Here's a summary from the ADA. This came from the 2012 guidelines, which I like. And then this also comes from the American. So, reduce the risk of hypoglycemia. All medication should be adjusted based on renal function, right? Anytime there's a GFR under 60, you at least have to think about the dosing of your medications. Higher glycemic targets are recommended. Deprescribing anti-hyperglycemic and other agents in high-risk patients is recommended. Appropriate discontinuation, withdrawal of diabetes medication who have tight glycemic control can potentially reduce risk of hypoglycemia and medication burden. And this is obviously how your targets and your therapy meld in together. Again, care plans, protocols, all of that is good stuff for you guys. And so with that, do you want me just to introduce these cases? These came from you guys. Or do you want me to take a couple questions on the content before we go to the cases? Questions before we go to the cases.
Yeah. What drugs do you like for reduced GFR?
Tradjenta is really sweet. Tradjenta or linagliptin. So that's the one we've listed in hospital because you can dose it down to a GFR of 15. It's the same 5 milligram strength. The other DPP-4s do have, and Tradjenta is a third-line special authority on PharmaCare. Saxagliptin and sitagliptin also have renal doses down to pretty low GFRs, but you have to look at the GFR and pick the dose. That said, nobody's ever told me what happens if you give too much DPP to somebody with a GFR of 20. We don't actually know what the side effect is. The dosing is just based on pharmacokinetics. Good old glargine, good old Lantus as monotherapy combined with a little bit of metformin, combined with a little bit of Tradjenta, you don't really have to worry about as it relates to renal disease. Sulfonylureas you absolutely have to worry about because of decreased clearance, especially glyburide. Metformin, most of the nephrologists would say is a thou shalt not with GFRs under 30. But even as you get towards 30, you probably want to be on a little bit less metformin. So the one drug where you don't have to think about it at all is linagliptin.
You have metformin on.
So there's a risk of lactic acidosis, which on the one hand is rare. John Antonsen will tell you that if he could completely control all drugs on all patients at all time, he could probably even dose it in dialysis patients. But the problem is, and this is the sad man's mnemonic, so these drugs that have to be held if you have a vomiting illness, if you have a dehydrating illness. The M in sad man's is metformin. Patient gets dehydrated, they keep getting their metformin, you know, they get an acute kidney injury, you know, they didn't have much to spare, and next thing you know, you've got a full-blown lactic acidosis, which, you know, quite frankly, in a nursing home patient is probably going to kill them. Those of you who know her, I've got a few patients that I share with Gayleen Hargrove where she has dug them out of lactic acidosis, and thereafter forever on her notes say, this patient has had life-threatening lactic acidosis, is never to get metformin again. And I say to the residents, I mean, God bless you, if you give that patient metformin and you cause lactic acidosis, you're calling Gayleen because I'm not. And you do not want to be making that phone call. Lovely lady, saves your patients, but if she's written that on the notes, she means it. And that's not described with DPP-4 inhibitors. It is unique to metformin. And of course, patients get confused. Patients think metformin is bad for kidneys. And so metformin is good for kidneys, but it's renally excreted in part. The other place that comes in is in hospital when people get angiograms and dye CTs, and we have to stop their metformin for a couple days. So I'm always very clear with the residents, no, dye is bad for kidneys. Metformin is not bad for kidneys, but if they get dye nephropathy and all of a sudden that GFR of 40 becomes a GFR of 15, that's the person who gets into trouble.
Any other questions? So targets was mostly what I had to focus on. The new, more relaxed targets for the frail elderly. Yeah.
Yeah, so I think we're just going to, again, get a little more subtle in our distinctions. And again, getting you thinking about, you know, is this somebody, you know, who is at risk of hypoglycemia? And that's where the lower end is going to come in. But if they're not at risk of hypoglycemia based on their pharmacology, then mostly we're going to have an upper end target. So I guess you pulled the room to get these cases, or are these yours? Who do I have to blame for these?
I think this is mine.
This one's yours? Okay, so I think I went in what you thought was order of difficulty, and I agree. So 86-year-old lady, moderate dementia, 3 grams of metformin, 100 milligrams of glycoside MR. I'm not quite sure how you came up with that dose. For something that comes in 30 milligram pills, let's say 120. So first up, I mean, 3 grams exceeds the recommended maximum of metformin. The recommended maximum is 2,500 or 2,550 if you like the 850 tablets. Truthfully, going from 2 grams to 2,500 doesn't accomplish a whole hell of a lot. I rarely go above 2 grams of metformin. So there, I've just saved 2 pills. Been stable, not eating much, complaining of nausea. So again, maybe we need to be invoking sick day rules here, right? If she's starting to get dehydrated, both sulfonylurea and metformin need to be held on sick days. Otherwise, not showing much. A1C 6.8, 7.0. Can we adjust meds in what order, how fast, and whatnot? So, you know, 86, moderate dementia. Does she have 5 years in her? Probably not. Is she at risk of hypoglycemia? Yes, because of the glycoside. Again, better choice than the glyburide, but still some risk. Now, you know, Ian hasn't told me that she is or isn't having hypoglycemia. Truthfully, much like infants or small children, she might not be aware she's hypoglycemic. So certainly back off on the metformin, that's easy. I'll take her back to 1,500 or 2,000. And that alone might push up her A1C. So I might start by just, knocking off or knocking back the metformin. And truthfully, even if she was having a little bit of hypoglycemia on this combo, if you cut her metformin in half, she might not have hypoglycemia, right? Because she's starting at a higher baseline. We see that all the time. When we start people on basal insulin, we get their mornings down to 7. All of a sudden, they get hypoglycemia during the day, versus when they had a fasting blood sugar of 14, they never had hypoglycemia. So the glycoside is the culprit, but there's still an interplay here between the metformin and the glycoside. And whether I did it immediately or whether I waited for 3 months, I might try to knock her back to 60 on the glycoside, a single 60 tablet. And this lady, probably is in the 7.5 to 8 category for our A1C target. And on the assumption that that's done without any hypoglycemia. Home blood glucose monitoring or bedside blood glucose monitoring in the absence of hypoglycemia, probably not that important. And I would say cutting the metformin and or cutting the glyburide would probably put about a point on to her A1C.
Measure again in 3 months?
Yeah. Okay. Yeah, I mean, she's not, again, she's not symptomatic from hypoglycemia. You don't have to really pull the brakes on. I would be a little bit afraid. I mean, if you stopped everything, I think she might bounce up to a 9 or a 10 A1C. She might start to get glucosuria. But maybe I'm wrong. I mean, maybe you cut her metformin in half and her A1C stays at 7. In which case you might get a little bit more aggressive at decreasing the glycoside.
Would you put the...
And that, of course, is all dependent on what her GFR is.
Would you dip her urine at some point for the glucose?
No, not at these levels. But if in backing off, if all of a sudden her A1C was 8.5 or 9, or if she was starting to get any sort of urinary tract symptoms, then yeah, good old-fashioned glucosuria is a reasonably predictive sort of thing. So it's a little bit of a back to the future thing for those of us who are old enough to remember keto diastics. I think there's maybe a role in some of these folks, or just a good old-fashioned urinalysis. Okay. So then you got a little more complicated and you got a little more wordy. So let me remind myself about this one. So 82-year-old, mixed dementia, moderate to severe, metformin 1,000 twice a day, Lantus 8 because sugars are consistently over 20, symptomatic when she gets over 25. A little bit surprised by the next comment that, okay, fine, she's inconsistent with her eating, but god darn it, 8 of Lantus causing hypoglycemia? Meh. The other caveat, of course, with that is when somebody's used to running in the teens or 20s, they may in fact be symptomatically hypoglycemic with a blood sugar of 6, 7, or 8. Right? So the concept of relative hypoglycemia, they're going to be symptomatic, but they're not going to fall over on you. And this is an issue for me with some of my type 1 diabetics. I feel best when my blood sugar is 8. Yeah, but that means you run at 12 all the time, and that's why, you need a kidney transplant. So in the type 1s, we have to work to break that. But, symptoms of low blood sugar may or may not correlate. So I alluded earlier, the older person may be hypoglycemic and not have symptoms. I'm going to argue this patient may not truthfully be hypoglycemic, but may have symptoms. And that applies to anybody. Refuses to eat before noon, refuses to do glucometers, refuses insulin 2 or 3 times a week. Yeah, now this isn't hard at all, Ian, thanks. No pattern, yeah. You guys know I talk a lot about pattern recognition, pattern management, consistency, and this person seems to be countering that at all costs. Interestingly, just despite my skepticism about, quote, 8 lousy units of Lantus, seemingly documented low blood sugars, but spiking at supper time and often bedtime, and then presumably when not eating gets those 3s to 6s. PRN insulin for sugar over 15, so you're kind of sort of using a sliding scale, but not a standalone. And given Lantus in the morning. So yeah, I get that this is difficult. I get this in hospital. I got a good one. So a guy, 48, he's already lost one leg. He's got a hideous infection. And the nurse calls me one morning to say, and he's on QID insulin, because I do that in hospital. The nurse calls me to say, well, his blood sugar is 20. Nice. Because as she was poking his finger, he was eating a cracker with honey and sugar. Somehow the honey and the sugar seemed a bit redundant to me. And, already having been downstairs for his smoke and his coffee and or his donut. So, sometimes people just won't let you help them. So this is a very interesting pattern where, in fact, it's almost counter, right? Most people with type 2 diabetes have a high morning, and then they typically get better as the day goes on. So they have hepatic gluconeogenesis, they have a leaky liver. No, doctor, I don't raid the fridge at night. There are these odd ones that almost are reversed. They're good in the morning, and then they start to ride high as the day goes on. In acute care, that's our prednisone patients. Right? If somebody gets 50 milligrams of prednisone, it reverses the diurnal pattern, and they'll show this pattern. 30-70 in the morning rather than Lantus. Something that, peaks through the afternoon hours. Again, not a huge fan of 30-70, but it actually, the profile of NPH, the profile of 30-70, matches the profile of this patient's blood sugars. I would certainly give the caveat that I wouldn't give it until he'd eaten his first decent meal of the day. So if he's going to consistently not eat breakfast on you, you don't want to tempt fate. But if he'd eat lunch for you, 30-70 at lunchtime, may be the way to go. I don't think Lantus is going to have enough kick to knock down those 20s.
Right.
So NPH, which has but yeah, if quote 8 lousy units of Lantus makes them hypoglycemic, I'd start at 6 or 8 of 30-70 and then titrate it to the supper time blood sugar. And try to keep the supper time blood sugar under 15. Right? One of the reasons we do fasting sugars preferentially, A, it's easy, but B, for most people with type 2 diabetes, it is the highest blood sugar of the day. And typically, if you can control the fasting, you can control the patient. But this is one of the exceptions. This is one of the outliers where the morning is deceiving you into what's going on. The other thing, and you didn't tell me, the other, if you get somebody with intermittent morning hypoglycemia, alcohol. Alcohol prevents hepatic gluconeogenesis. Big topic of conversation for my 18, 19, 20-year-olds. But, in a dose-dependent fashion, alcohol decreases hepatic gluconeogenesis. So if somebody's, doing dial-a-bottle for this guy, if he's still drinking, I don't know, but just as a teaching point for, younger patients and elderly patients, I always ask about alcohol when there's morning hypoglycemia, because it's not a common time. Especially if the pharmacology doesn't fit. If you're giving the guy a boatload of NPH or a boatload of insulin, okay, fine, that explains the hypoglycemia. But if it just doesn't quite make sense as to why they're hypoglycemic, think about alcohol.
Okay, let's do the next case.
Lantus?
Probably not. Lantus is supposed to be 24 hours. It does have a little bit more activity in the first 12 than the last 12. I have maybe 10% of my Lantus patients I do at BID. Tends to be people on the extremes of doses. So some of my little ladies with type 1 diabetes who are like super sensitive to insulin, I do find twice a day Lantus is maybe a little better for those. Or my big fat guys on 100 units of Lantus a day, they got to poke themselves twice anyway, so they might as well go 50 in the morning and 50 at night. But you're right, and I don't think just changing the timing of the Lantus is the answer for this guy. And then he just kept getting wordier and wordier. Yeah, 82-year-old, type 2, mild to moderate neurocognitive. Not a bad GFR there, between 50 and 60. Metformin, low dose, glyburide, A1C around 10, so glyburide discontinued, NPH 10 at bedtime, titrated up to 16. Okay, that seems fine. Blood sugar high, lunch and supper, right? Because the NPH is really only going to control your fasting blood sugar, right? Although it's maybe a 12 to 15 hour insulin, you're just titrating it to your breakfast reading. So started NPH 10 at breakfast, increased to 16. A1C improved to 8, so that makes us pretty happy, right? That's about where you would want this guy, maybe even 8, 8.5. And then the A1C starts to creep up. All blood sugar high except breakfast. Nursing not checking. Lots of sweets, cookies, chocolates, blah, blah, blah. So again, we've got somebody who may not really be able to help themselves and otherwise stable. So again, you're looking at the pattern here. So, and again, how symptomatic, is there glucosuria? Do you want to just tighten up a little bit? Female, so, incontinence type issues, maybe a little bit more likely. Urinary tract infections, maybe a little bit more likely. NPH versus 30/70, okay, fine. But again, looking at the pattern, if the breakfast is good, that tells you the bedtime insulin is adequate. But if they're riding higher through the day, yeah, maybe it's the cookies and chocolate. Or maybe you could just gently nudge up that morning dose because you need something that's acting through the day. And again, if the problem is intake of calories, intake of sugar, you're trying to match your insulin with when they're doing it. Of course, where you're going to get in trouble is when this intake is irregular. So again, you just want to, probably titrate to the bedtime or the supper time. And if you could get, the supper time blood sugar under 14, then on those days when the patient isn't eating cookies, maybe she'll just bottom out at a 6 or a 7 and not at a 3, 4, or a 5. So again, looking at the pattern and a little bit of home blood glucose monitoring, you have to take, right? I mean, had a very bright lady in my office today, A1C of 9, really high functioning 75-year-old, doesn't like to do home blood glucose monitoring, and it's like, I can't start you on insulin unless you do some home blood glucose monitoring. I can't adjust the dose of your insulin just on the basis of an A1C, right? If you're going to adjust the insulin, you can make decisions about metformin, glyburide, DPP4s based on an A1C. You can't make decisions about insulin just based on an A1C because these last two cases have represented it, right? A, it's just an average, and B, it doesn't tell you what their diurnal pattern is. And also why you can't necessarily just rely on a breakfast blood sugar, right? You might be fooled with this patient, oh, all the fasting blood sugars are good, I'm home free, but then you can't explain why the A1C is 9.5 or whatever. And again, I go through that in my office, right? Yeah, great, your mornings are all 6, but I've got data that says your average is 12. So at some time during the day, you've got to be 15 or 18 or whatever theory we learned in first year calculus falls apart. So again, and it's of course patients on their own, they're real cute. They'll know what time of day they have the best blood sugar, and that's when they'll want to test. Because nobody likes to test and see a bad blood sugar. So when patients do actually target their trouble spot, I really compliment them because it runs completely counter to human nature. I got a very sweet old Scottish lady, and although she is on multiple doses of insulin and she sees Renee Weir, she says to me one day, Dr. Miller, when I get a blood sugar of 17, I just don't like to write it in my book. And I go, well, God bless you, dear. You do the test, you adjust your insulin, and you come and talk to me. And so if I see a little blank in your book, I'm just going to assume it's over 17. We can just have that as our little code between you and us. So, but again, she diligently does it, and she adapts her behavior, and she admits to whatever sort of Scottish or Irish shortbread she's gotten herself into, and she doesn't do it for a few more days. So she does learn, doesn't like to write it down.
Good, thank you so much.
Thanks, guys.
I noticed you didn't discuss the SGLT2.
Yeah.
Is that because in elderly that may be just something better to be avoided? Or?
Well, again, because of the dehydrating effect,
Yeah.
and also because your patients are more likely to have sub-60 GFRs.
Yeah.
The SGLTs, they certainly don't work if the GFR is under 45,
Yeah.
and they don't work as well if the GFR is between 45 and 60. So, I mean, you guys tell me, what portion of your patients have GFRs over 60? 10?
Yeah.
Yeah. Right? Now, there's a bun fight in Canadian diabetes around, empagliflozin in people who already have cardiovascular disease, because it's actually shown to reduce subsequent cardiovascular disease. There's a very small amount of elderly patients in that study. Interestingly, they gave it in the study down to GFRs of 30. So does it prevent heart disease because of its glycemic lowering, or it's also a damn good diuretic? And by fluid downloading people, maybe that's why it prevented cardiovascular disease, and even though it didn't lower blood sugar very much. But Grady Manili, who I work with a lot, he's still pretty leery about the SGLTs in, frailer elderly. Really, in anybody over the age of 75, we're pretty leery about it. I love it in my young people, but that's the deal. So I think until we have a little more data, and until you all can get your nursing home patients to have better GFRs, they're probably not going to be big players in your group.
Right.
And risk of genital mycotic infections. Don't think they increase the risk of true urinary tract infections, but the little yeasties are real, and the dehydration is real.
Yeah.
Great.
Thanks, guys. Thanks, Warren.
Thank you.